Hello, my name's Kate and I've been asked to do a short video for you on a topic related to endodontics. So I've picked pain diagnosis because I thought that was a good place to start. Have you ever had a patient who presents in pain and you're unsure where it's coming from? So let's look at basically pulpitis. So we know that bacteria causes pulpitis, and acute periodontitis is inflammation of the periodontium. Pulpitis causes clinical symptoms including pain, swelling, redness, tenderness, and sometimes impaired function. So just briefly, let's just run through the nerve pathway in the dental pulp. This is obviously quite a detailed topic in itself, so I'm just going to go through the basics. You've got two different nerve pathways in the pulp. The first is fast conducting myelinated A fibers, and the second is slow conducting unmyelinated C fibers. Each of these fibers has a different pain characteristic, and the A delta fibers normally evoke a rapid, sharp, and sort of searing pain. C fibers cause a slow, dull, and crawling pain. Evidence points to the fact that the incidence of pain normally increases as the disease process worsens, and patients who manifest severe or referred pain almost always have a previous history of pain in the tooth with the ache. So, patients presenting with pain. Questions I'll always ask patients when they come in are: one, where do they feel the pain's coming from? Sometimes this isn't always apparent. Secondly, how long has the pain been going on for? Then a description of the pain, and normally asking on a scale of 1 to 10 gives you a good idea of how severe obviously that pain is. Does anything make the pain worse or better? And also a history of any previous pain from around the site that they're saying is now painful. Important to remember that any referred pain will always be on the same side of the mouth and will always only be around posterior teeth. So special tests, a patient comes in with pain. What do you do if they're saying it's somewhere, it's everywhere, somewhere, everywhere, or on one side of the mouth? It isn't always totally obvious where that pain's coming from. So I'll do special tests, and I normally spend, actually for patients who aren't very clear on where the pain's coming from, I normally take quite a long time doing special tests, including teeth, around the site where we think it might be coming from. So the electric pulp tester is used to provide a small current to test the integrity of the A fibers. It doesn't, however, give us any indication on the blood flow to the pulp or whether it's partially damaged. You can also use heat or cold stimulus to the A fibers, and the pulp response, lingering for more than about 30 seconds after the stimulus is removed, normally indicates that the pulp is likely to be irreversibly inflamed. As I said, I will always test adjacent teeth. Everyone's different. Some people will have teeth that respond at 1, and you'll get another patient whose teeth respond nearer to 10. No response is normally indicative that you've got necrotic pulp. And the other thing I'll always do is get a perio probe and probe around the tooth or teeth in the area where the pain's coming from. Probing can be a really useful tool. Just a quick bit on just remembering false positives and false negatives can exist. Just run through some false positives. This includes if you've got liquefaction necrosis, contact with metal, amalgam, or a crown will cause a false positive, and also vital tissue which is still present in a partially necrotic root canal system. Then some false negatives, incomplete root canal incomplete root development, traumatized teeth. Now, this is quite important because it can take up to 9 months for the nerve supply to recover following a trauma. And I have had some patients where this does happen, and if you're not aware of that, you can end up root treating teeth that would have recovered. Sclerosed canals, and also recent orthodontic activation. It can take up to 2 to 3 months for the nerve supply to the teeth to be normal. And then also just to remember that patient with psychiatric disorders on sedative drugs or with alcohol addiction can cause some false negative results. So clinical presentation, if someone arrives in your surgery and they're saying they've got pain, what are we looking for? I normally check if any of the teeth are tender to percussion. Then I'll run my finger in the buccal sulcus to check if there's any tenderness around anywhere. You can sometimes see swelling, or there may be a buccal sinus present. Looking for any obvious cracks or defective restorations. Any tooth that is being avoided in function is normally a good sign that something is going on. Probing depths, as I said before, can be very useful, particularly when you think there might be a crack. And then extraoral swellings or lymphadenopathy. And then taking all the clinical presentations combined with sensibility testing will help with the diagnosis. And then we've also got obviously special tests to include radiographs or CBCT scans. So this next slide just shows some obvious presentations of things that we'll look out for when we've got pulpal disease and pain, ranging from, on the first x-ray you can see there's obviously clear chronic apical periodontitis. We've also got some x-rays that show the beginning of the disease process, where you just get widening of the periodontal ligament, and then that can be combined with acute apical periodontitis, and then you've obviously got bigger lesions when the disease process is more advanced. So then I just thought I'd pick 3 cases really just to run through with you. The first presentation was someone who came in pain from the upper right quadrant. I took a photo because there were actually 2 buccal sinuses present, and the upper right 4 was tender to percussion. I stuck a GP point in the first sinus, which clearly sort of went between the 4 and the 5. I also took a CBCT scan actually for this case, and it was quite interesting to see that there was quite a large area associated with the upper right 6 as well. So I diagnosed that upper right 4 had necrotic pulp and needed obviously root canal treatment followed by cuspal coverage restoration, and the upper right 6 was then booked in, or is due to be booked in, for root canal retreatment. So you can see on this slide, obviously the upper right 4 has been root treated, and this a couple of screenshots of the CBCT scan just to show the area associated with the suboptimal root canal treatment on the upper right 6. Second case was a lady who came to me in pain, or she'd been to see a colleague first, who had, I think a few months prior, had opened the lower left 6. The tooth then settled, even though they hadn't been able to locate any canals. She then came in to see me to have the root canal treatment done on the lower left 6. On the day she presented, she was actually in quite a lot of pain, which I explained to her could well be due to the fact that obviously no one had found the canals on the first appointment. So we proceeded with the root canal treatment. Later that day, she phoned and said the pain was getting much, much worse, and she hadn't felt the treatment had helped. So I did get her back in, and I just reviewed things on the x-rays, and actually I hadn't noticed on the pre-op, probably because it wasn't as apparent, but on the post-op, you'll be able to see that the pulp in the lower left 8 looks odd. So I actually sent her for a sectional OPG, and that came back. And I diagnosed root resorption on the lower left 8. So she actually ended up having the lower left 8 extracted on the same day that we had actually completed the lower left 6. So I guess this case to me just highlighted that, particularly when I'm getting patients referred in, is sometimes just need to be a little bit careful just to obviously check what else might be going on. Last case, another patient referred to me, came in saying she had pain somewhere on the left-hand side. It was a bit vague. Quite a lot of previous treatment had gone on, a root treatment on the lower left 7 and a root treatment on the upper left 6. Although the lower left 7 root treatment looked suboptimal, there wasn't anything really to be seen. There wasn't anything to suggest there was an apical area associated with the lower left 7. Anyway, I did sensibility testings on the lower left 6 and the upper left 7. Both responded positively to endofrost and also the electric pulp tester. So decided to take a cone beam CT for this lady actually. And you'll see here, you can clearly see that although the root treatment actually looks like it had been done to a reasonably good standard and the MB2 had been found on the upper left 6, the CBCT scan clearly showed that there was an area around both of the buccal roots. So I retreated the upper left 6, and then we decided to bring her back and also retreat the lower left 7 just to rule out that wasn't causing any problems, and thankfully all her symptoms settled down. So in summary, always take a very detailed pain history. Previous pain can be a good indication on what is going on. Use clinical symptoms and sensibility tests together to get a diagnosis. Don't just rely on one. And use special tests to confirm your diagnosis, so x-rays, CBCT scans if you've got access to one. And also, I guess it's important to say, if there's no obvious tooth causing the pain, then consider could there be another cause, maybe a neuralgia or a non-odontogenic cause for the pain. And sometimes pain diagnosis is simple, other times it takes time to reach a diagnosis. So just don't ever feel rushed. Thanks very much for your time, and I hope you enjoyed the presentation.